So, good evening, good afternoon, good morning, dear colleagues, audience, and distinguished speakers. I'd like to welcome you all to this webinar titled Building Resilient Immunization Program, Reducing Vaccination Inequities. Globally and in the EMR in particular, many countries are facing a broad range of emergencies resulting from various hazards, which differs in magnitude, scale, complexity, and consequences. These emergencies have proven how critical it is for health system to be prepared for challenges before they occur. These emergencies in general and the COVID-19 pandemic in particular have proven how fragile health systems were ill-equipped with the essential elements of resilience, which necessitate the exploration of approaches that build and improve health systems to be better prepared to respond to emergencies while maintaining delivery of essential health services. In November last year, WHO and UNICEF warned that millions of children are at high risk of polio and measles worldwide due to disruption of immunization services because of COVID. Resilient health systems have the potential of recovery much faster than the others. Health systems are described as resilient when they can identify potential health risks, as well as they are equipped with strengths and strategies that enable them to respond to these emergencies. Continuous and uninterrupted immunization is a crucial area requiring special consideration, especially during emergencies. Prioritization of immunization services as a key component and an integral service or an integral component during the response to the emergency is very important and crucial, and also could minimize the impact of the pandemic or any emergency or even the economic loss due to this interruption. For immunization programs to be resilient, universal health coverage must be taken into consideration and promoted within health systems, and not during the emergencies, but also during the normal time. So we have the potential to build our systems so they can respond on time appropriately. Thank you very much for being with us. And now let me to welcome my guest speakers, Dr. Frank Mahoney and Dr. Ghulam Dastagir Nazari and Dr. Stephen Sosler. Welcome and thank you very much for being with us in this webinar and accepting also the invitation. I would like maybe a small note before starting our first presentation that for our colleagues, audience, please use the Q&A box for posting your questions. We will try our best to respond to these questions in the Q&A session during this webinar, as well as the remaining questions. We will try to address them separately after the webinar in our brief. So we are sharing a report or a brief on the webinar that will be shared with all participants. Thank you very much for being with us in this evening. And our first speaker is Dr. Frank Mahoney. Dr. Mahoney is an infectious disease epidemiologist seconded by the US CDC to the International Federation of Red Cross and Red Crescent Societies. Prior to the current assignment, he worked on polio eradication in Nigeria and was the CDC team leader of Ebola response in Nigeria and Liberia. Between 2007 and 2011, he was head of the CDC office in Indonesia and worked on the response to avian influenza. He also worked for 10 years in our region, in the Eastern Mediterranean region, in the WHO office and with the US NAMRO 3 in Cairo. He leads the WHO working group on outbreak response and vaccination of children who live in fragile contexts. Dr. Mahoney is an author of numerous publications and book chapters and has worked with FETB programs during his career. He is graduated from the University of Texas Medical School and completed residency in family medicine in Baylor University. So thank you very much for joining us. Welcome, Dr. Frank, and the floor is yours. So you can start your presentation. Thank you very much.
Okay, shukran, Doctor. Can you see my screen? Yeah. Dr. Majid, can you see my screen? Okay, is everybody?
Yes,
yeah.
I can see the screen.
Thank you very much for inviting me to participate in this seminar. I really think it's very timely and important. I think, as you'll see from the data and the presentation, these children living in fragile and conflict settings are really a big part of the disease burden and missed children globally. And I think it's really important to highlight this important issue and trying to figure out ways we can reach them. I'm going to give a brief global update on the status of EPI. I talk about the context of providing services in conflict settings, discuss a few lessons learned, and discuss kind of key strategies that have been identified by people working in these sectors that may be efficient ways to reach children. This slide shows the number of undervaccinated children since 1980 through 2019, as well as percent vaccinated coverage. And you can see in the past decade, we've kind of stagnated globally at around 85% of the world's children are receiving vaccine, DTP vaccine. Most of the missed children reside in Africa, around 9.4 million, followed by the Southeast Asia region and EMRA region. You can see there are 10 countries that account for many of these children, and several of those countries have communities affected by conflict and fragility, including Nigeria, DR Congo, Pakistan. And very often in those countries with high numbers of missed children, it's in areas of civil conflict where most of the children are residing. This slide shows the trends in the overall number of zero-dose children from 2010 to 2019. And by zero dose, we mean children that don't receive any immunization. And as you can see, we've really not made progress in reaching the zero dose children for the past decade. Some countries, like for example, as you can see in the graphic, Nigeria and Pakistan, India have been reducing the number of zero dose children, but other countries have experienced an increase, such as the Philippines and DR Congo. And so going forward, reaching those zero dose children is a high priority for both the IA 2030 efforts, the WHO efforts to improve immunization, as well as the plan for Gavi 5.0. And we'll probably hear, I'm sure we'll hear about that from Stephen when he gives his talk. In addition, as an outcome, or as you would expect, that due to the low coverage, many of the fragile contexts are experiencing large outbreaks. And this slide shows a global trend in measles cases. And you can see that we've had a resurgence in measles in 2018 and 2019. And in 2018, the highest number of cases were in the EMRA region, as well as the European region, and many of those cases in those regions were in countries affected by conflict, in particular Somalia and Ukraine. And then in 2019, we had large outbreaks in Africa, and again, really an outbreak of unprecedented size in Democratic Republic of Congo, which accounts for much of the peak in the Afro region in 2019. Similarly, with polio, many of the cases of obviously the ongoing circulation of wild polio in just two countries, Afghanistan and Pakistan, are in countries affected by conflict, but also the outbreaks of the circulating vaccine-derived polio. It tends to be concentrated, it is concentrated in countries with low routine coverage. And again, many of those countries are those affected by conflict. Kind of providing services in these countries is challenging. And I think we've had really dynamic changes in the evolution of civil conflict over the past 3 decades. There've been an increased frequency of wars from 16 in 1991 to 41. Most conflicts are between groups within countries. The conflicts tend to be longer lasting. The average duration has increased to 17 years, and particularly when it involves external military support in a conflict. Conflicts are more disruptive, resulting in more more displaced persons, and that's increased from 43 million in 2009 to 71 million in 2018. It's estimated that 1 in 6 children live in a conflict zone. Another evolving issue of great concern is that civil conflicts have had on health infrastructure, not only on immunization, but overall health services. And there have been a number of attacks on health facilities, as you probably, many of you are aware. DTP3 coverage is around 60% in conflict affected countries compared to the 85% globally. And this little infographic on the right, WHO has established a surveillance system to monitor attacks on health facilities, just shows the attacks just related to COVID-19 in the past 2 years. So I think even it's very dynamic even now with the COVID-19. This slide kind of gives some examples of the impact conflict can have on immunization coverage. The top, it shows trends in vaccination coverage in a 5-year period post-onset of conflict. As you can see, in both Iraq, Syria, and Ukraine, there was a remarkable reduction in EPI coverage. Iraq has since recovered somewhat, and coverage has kind of gone up to pre-conflict levels, but it's remained low in Syria and Ukraine. And of course, many of you that know Syria well remember that it used to be one of the best programs in the region. And so it's really unfortunate that they've experienced this problem. This slide shows the long-term trends in countries with persistent conflict, Afghanistan, Somalia, and Liberia. And I kind of, wanted to just share with you, I think if you look at the conflict during the Civil War in Liberia, they had very low coverage. They recovered, and then they had unrest that resulted in drops in coverage. And particularly in 2014, you can see the drop in coverage in Liberia due to the Ebola outbreak, and that they are just now recovering from that. So it's just not, so it's civil unrest due to, I think we're going to probably see similar effects due to COVID-19 impact on immunization services in many countries as a result of the negative impact COVID has had on delivery of EPI services. Some of the lessons learned, obviously there are many challenges when working in conflict settings, insecurity being a big one, having availability of trained staff that can provide services in these areas, loss of infrastructure and supply chain. There's issues of mistrust between service providers and the communities they're serving, population displacement and migration, as well as issues of data quality. And then finally, many communities living in conflict settings have a lot of unmet health needs. And very often if you want to deliver services, I think very often the anti-government elements will not accept a standalone immunization package, that the communities really want an integrated package of health services because they generally don't have access to any services. And so I think a lot of the pushback on programs like polio in some of the conflict areas in Pakistan is related to these unmet health needs, and parents want something more than polio drops for their children. Let me share a couple of examples of successful models of providing services in some of these conflict zones. This is a map of the Central African Republic, and the Red Cross started working in 6 districts shown on the left in 2018. And then these are areas where other partners were unable to work for many years. And so they had to, the Red Cross was one of the few organizations that was able to have access and support the immunization program. Despite the conflict, we found that a number of the health facilities were still in place, and a number of the healthcare workers still were working in those conflict areas. And so we started with a very methodical approach with microplanning, where we engaged all the facilities and communities to participate in this exercise. And we were trying to push all facilities to provide RA services. We developed a district microplan in every district where we had a list of all the villages that included their population data. And we worked with the district health team to make a schedule of vaccination, fixed, and outreach. And so we kind of called this facility-based microplanning. We identified community volunteers who worked in the clinic to support the services, as well as community volunteers to track newborns, pregnant women, and defaulter children. And one of the values, very often in conflict settings, as many of you know, it's very hard to know the resident population because there's been so many displaced persons in the community. So doing this walkthrough microplanning exercise was really useful in characterizing the actual denominator for the immunization program, how many targets children there were. And you can see the difference in estimated population data. For example, for Nana Grabuzi, it was 156,000, but the actual population residing in that area was 229,000. So we did this district by district, and we were able to adjust the data to establish firm denominator data for each district, so they could really use a data-driven approach to monitor their immunization program. They were rapidly improved coverage in these areas after this exercise, and kind of the ongoing work is to get more and more of the health facilities stood up to provide immunization services. Another key aspect of working in conflict setting is establishing trust between the providers providing services and the community they serve. And again, listening to community, novel approaches on hearing community concerns is really a value in trying to improve service delivery. This case study involved an approach of using community volunteers to report what they're hearing in communities related to the Ebola vaccine in DRC. And this is a lot of qualitative data that was systematically collected and then used to help address the issue of vaccine hesitancy. And it was an ongoing effort to listen to communities, to capture the information, and adapt the Ebola response in DRC. Some of the findings is there was a lot of misunderstanding in community about the side effects of vaccine, who was eligible to get vaccinated through this ring vaccination strategy. There's a lack of understanding about how vaccines work. They didn't trust unknown healthcare workers to administer vaccines in their communities. They thought that the vaccine was being provided in unusual locations that made them suspicious. They were concerned about police at the vaccination locations, and they felt like there was a lack of training or information from some of the providers who were unable to answer their questions. And so they had some mistrust of the healthcare workers. I want to provide some summary of there's a lot of global working groups working on this issue. There's a group called the Equity Reference Group and the IA 2030 group on fragility. And I think they've summarized, and I provided some references at the end of the talk where you can access this information, some of the key interventions that are important in these things. And one of obviously the title of this webinar is building a resilient health systems. And I think I think we all agree that health systems need to be flexible enough to provide services or continue providing services during times of crisis. That national health plans ought to be supporting an integrated package of services. They need to find trusted providers that can work in these areas. Very often, CSOs or partners in the humanitarian sectors should be the providers of choice, perhaps even instead of a government run system. It's important that recovery plans are part of emergency plans of actions. I think very often the experience has been when there's conflict, people will be displaced into urban settings, and that urban centers need to have capacity to provide services to those displaced persons. They're very often, they're not necessarily in IDPs, but they're living in the urban settings. More often than not, the great majority of people are living in urban settings, not in IDPs. We need novel ways to pay for staff in conflict zones, for example, digital financial services and mobile payments. There are tools that have been developed to capture reliable census of what's functioning health facilities. So for example, in an acute crisis, it's good to know what clinics are working. And so there are very different tools to do that. And then there are tools being developed in the immunization side to characterize who the zero dose children are and why they're missed. In terms of service delivery strategies, obviously vaccination in camps and other mass gathering sites is an important strategy. Negotiating access into conflict areas is an important part of what humanitarian organizations can do. And one of the big challenges when you're talking to anti-government elements is whether or not they actually represent all the players in a particular area. And I think Dr. Nazari can probably shed some light on the challenges of doing this in a country like Afghanistan, where there are multiple armed combatant groups. From reestablishing fixed site services is of value. One of the things we found surprisingly in CAR, even though a lot of humanitarian partners came in during the crisis, established certain treatment centers, most of the services were still being done by government-run clinics. Finding trusted providers like Save the Children, Red Cross, MSF, who can do outreach and mobile health teams is value. Periodic intensification of routine services, hit and run vaccination. And hit and run is quick and in and out operations to provide services during tranquil times. And very often you can talk to combatant groups who will agree to stop any activities for a short period of time so people can provide services. Establishing vaccination posts around inaccessible areas has been used in many countries, in northern Nigeria and Pakistan and Afghanistan, and transit and cross-border vaccination at checkpoints. It's important to have think about what's happened in these communities if they've been not receiving services for a long period of time. There should be some flexible age, if there are cohorts of children that didn't get any routine immunizations, then programs are considered to have a flexible age and think about what are the most important antigens to provide based on the local context. We're waiting for innovations on advanced cold chain support and delivery. We think that it's important to leverage humanitarian deliveries and logistics, linking them to immunizations. For example, if the World Food Program is delivering nutritional supplements and things, as best you can link that with a immunization service, would take advantage, leverage those opportunities. Using appropriate vial sizes to vaccinate sparse populations, to reduce wastage is important, and having long-acting cold boxes or vaccines that are stable outside the cold chain are important. And obviously using mobile technologies to support surveillance, M&E, and demand promotion. There's been a lot of work on using satellite imagery to characterize where the communities are living. This is a satellite image of the city of Bo in Sierra Leone, but they use this in Borno to find displaced communities and better able to characterize where the target populations are living. And as I mentioned before, adapting the cold chain to prepare for disruptions is of value in the long term, improves stability of vaccines and community engagement strategies. These are the resources that are available. There are many others that these will lead you to. So in summary, there are a large number of zero-dose unvaccinated children residing in fragile and conflict settings. There are successful models to reach these. I think I just shared one or two. There's many others. And key aspects of these models include a resilient health system, engagement of trusted providers, and innovative service delivery strategies. Thank you so much.
Thank you very much, Frank, for this very rich, comprehensive presentation, which shed a light also on different experiences from different parts of the world, and also how can we better utilize some of these lessons learned in the region. As I said at the beginning, that I'm still just reminding colleagues that they can post their questions in the Q&A box, and we have many of them, and we will have one session at the end of the presentations to answer these questions. Maybe I can use one question as a hot issue that I think which is very important. How did IFRC produce new denominator estimate in their micro-planning exercise, which was the process produce this revised estimates? I think the denominator is one of the key challenges, not only in countries under emergencies, but even in other countries where there is the data component is a very crucial issue. Could you please, Dr. Frank, elaborate on this?
Yeah, I mean, essentially, Dr. Najib, we did a walk-through microplanning, and we recruited community volunteers to do a census of all the people in literally every village in the districts, and we collated that data at the district level, and the minister, accepted that data as the official data, which is unusual. Most countries will stay with UN estimates and things, but the minister said, we want to use this as a new denominator. We had, when I worked in Northern Nigeria, we did a similar exercise, checking, very often there are challenges with the denominators, and we did walk-through microplan where we counted literally every resident in these different communities. And very often we would find that the target populations were almost what was being reported as the official target population was very inflated. And, we actually changed our denominators during that time, and everyone said, oh, you're going to run out of vaccine, you're not going to lose coverage, da, da, da. And in fact, none of that happened. That in fact, after this exercise, the denominators we found out were actually accurate and were better. We were better able to use a data-driven approach, improve the quality of the data because we had a better handle on the denominator.
Okay, thank you very much for this clarification. And now we'll go to our second speaker, Dr. Ghulam Dastigar Nazari, who is the Director of the National Expanded Program on Immunization at the Ministry of Public Health, Afghanistan. Dr. Nazari also worked as a senior advisor prior to his latest assignment as the EBI manager for the National Emergency Operations Center at the Ministry of Public Health, where he worked on the National Emergency Action Plan for Polio Eradication. Also, prior to that, Dr. Nazari worked as a senior advisor to the Minister of Health in the Ministry of Health. Dr. Nazari has a post-graduation diploma in clinical research and a Master of Hospital Administration from Maulana Azad University, India. So we are delighted to have you, Dr. Nazari, with us today for this presentation, and we will have now the flavor of one of the countries with a highly over-challenging situation. So welcome, and the floor is yours.
Thank you so much, and good morning, good afternoon, and good evening to all our colleagues from different parts of the globe. It is sometimes very unfortunate, as I mentioned in the beginning of this call also, the discussion between me and few colleagues, that it is really unfortunate that we could not see our friends and colleagues very frequently and have these webinars in person. But we look forward for this immunization activities goes on, hopefully by 2020, and by end of 2020, we can come back to our normal life. So I will start showing my screen. So, and then I will go with a presentation. Just a second. And now we will be there. Okay, and if it is okay with everyone, I will shut down my camera. It is not because I am a shy of camera, but my network will create problem in between, and I don't want that happen. So I'll just off my camera and I will try to just full screen so every colleagues could see my screen very rightly. I hope it is visible for everyone. Well, thanks to Frank Mahoney for explaining the presentation. It was a wonderful presentation, and I believe that I'm going to talk about few of those challenges in a context where we have the arms groups active, then active war going on, and how we are going to implement the immunization services. At the same time, the populations are, there is an active war going on. People are asking for all other activities, which is their rights to have them. But at the same time, we go with only few antigens, or even sometimes it only 2 drops in case of Afghanistan for polio eradication, and we ask them to vaccinate their children, but sometimes we receive a very different kind of answers, that we are dying of hunger, we are dying of war, we are dying of sanitations, and you are coming only with 2 drops, or even with 13 antigens or 12 antigens. So anyhow, let's have the discussions about these challenges. Well, those emergencies usually we have in the past 5 years in Afghanistan is the most important one is, of course, polio eradication is something that polio outbreaks are something that we have in the country, and the eradication of that polio is one of the biggest priority for the government of Afghanistan, and at the same time for the entire globe. Measles outbreak we usually have in the country. Unfortunately, Afghanistan is one of those countries. Still, we are not eliminated the measles. We are still having lots of cases of measles each year, and many deaths of children unfortunately happen due to the measles disease. So, and the third one was happened in the end of 2019 and beginning of 2020, COVID-19 pandemic within the country. So let's talk about measles. As you can see in the graph, Afghanistan, we have experienced multiple outbreaks of measles in Afghanistan in the past few years. If you can see, like in 2016, we had like more than 110 suspected cases, basically cases. And then when we go to the lab confirmed, then the number goes reduced. Of course, we could not go all the cases for the lab confirmation. That is the reasons the graph and the numbers is a little bit lower. But as you can see, as the years goes, 2017, the number goes higher, then 2019, the number goes higher, and then all of a sudden in 2019, the case is reduced. That is because in the end of 2018, we had a measles campaign that is for children up to 10 years of age. And luckily, we could sustain those lower number of cases in 2020 as well. Despite of having a challenge of outbreak, measles coverage was really gone down, but we could revitalize our activity that I will talk about it in the future slides. In the measles responses, as you can see, usually when an outbreak happen in one corner of the country, we ourselves picked it up, and then we came to know that there is an outbreak going on in this particular area. Our team goes there. The NGOs, the non-governmental NGOs who are contracted the entire health services in those provinces usually come into the picture. And with the provincial API management team, they go and see the area, they investigate, and then we have a sort of responses to those outbreaks in the country. And luckily, if you can see on the right side of the screen, we had the coverage variations while our responding to the measles outbreaks in the past few years. And of course, it depends on the areas, it depends on the which particular area we have the outbreak. Sometimes it is, the area where we does not have access in terms of geographical access because of the very remote situation, and at the same time the security access. Sometimes it is really difficult for our teams to go to conduct measles campaign until unless we does not negotiate with the community elders, through the community elders with the AGs. So, but overall, if we can see, we can see that the responses for those outbreak was done in multiple years, and that is with such a challenging situation. The next slide, as we mentioned, we are talking about polio outbreaks. Well, Afghanistan is unfortunately one of those two countries where we have still polio outbreaks in the country. Again, if you can see the slides, the number of cases of polio in the past few years has been increased and instead of decreasing. In 2016, we had 13 cases, and that was the lucky year when I was working with as an advisor to EUC, and on that time we were able to stop the transmission of polio in Afghanistan, but unfortunately due to the our neighbor country, we as a one epidemiological block with Pakistan, the virus get in Afghanistan, and unfortunately it starts circulation within the country due to the low routine immunization coverage, particularly in south of the country, and to be very particular in Kandahar itself. And then the internal circulation get started, and I will come to the challenges, but unfortunately the number has been increased, and in 2020 we had around 56 cases of polio across the country. Well, usually for outbreak responses, as the polio eradication, as I mentioned, is one of the biggest priority of the government and Ministry of Public Health. Usually the coordination mechanisms between BPHS implementer, PMT, the provincial API management team, and RMTs, regional API management teams, usually happens to support, to kind of, strengthen the supportive supervisions and monitoring, and have a very close eyes on the outreach and mobile sessions to increase routine immunization coverage as a most important strategy for polio eradication. Well, usually when we receive the AFP0 cases of RI, usually a team of WHO, UNICEF, a BPHS implementer, and the government PMTs usually go together to see and kind of do the assessment and investigation for the AFP cases, and usually after that, we try to have a response for those AFP0 doses in terms of routine immunization to find those children under age of 2 years to vaccinate them with all the antigens, and under 5 with the polio vaccine. Local negotiations sometimes, because as I mentioned, the ban is there in Afghanistan, and I'm going to talk about that in detail more. And since 2018, which is approximately of Hello?
Hello, Dr. Nazari.
Can you hear us? Can you hear me?
Yes, go ahead.
Oh, okay, sorry. For 1 second, I thought that I cut from the network, but anyhow, that's good. So usually we do the negotiation through the influencers and the community elders with EGs to allow the parents and children to bring their children to the nearest health facility for the vaccination. At the same time, we take this meeting with the district team, and again we have to have the negotiation with AGEs to talk with them and then ask them if we can have a response for that number of polio cases or those number of measles outbreaks. So we have to, this negotiation is sort of part of the routine of each activity that we need to be done in each in the control government, in the control area by the AGEs. And the other work, while the campaign was banned in the few years, we tried to establish few sub-health centers where we have the basic health services, including immunization in the government control area where we are not allowed to have campaign house to house. Well, we are trying to revise our micro plan and update them. As you all know, that is the most important part of the program for having a real location and real number of children, a target population in each catchment of each clinic, and at the same time at the cluster level. So we try to update our RI micro plan, and at the same time update our polio micro plan each year. At the same time, we usually, as I mentioned, it's a polio program. We have our NIDs, National Immunization Days. We have our sub-NIDs. And at the same time, we are having we are using multiple type of OPV vaccine. We use MOPV, we use BOPV, and at the same time, in the year 2020, we had we used TOPV as well. Although it was not a part of routine program, and it was ruled out from the routine program, and there was no type 2 cases. In 2016, it was ruled out, but unfortunately, due to the CVDP cases in the country in 2020, we have to introduce it back into the polio program. Well, the another work that we could we did in response to polio outbreak in such a situation where ban is there, we are not have access to the more than approximately 45% of children. We try to increase the age of children for polio in the routine program up to 5 years. Usually before this year, before 2020, it was under 1, or I would say under 2, to receive polio and all antigens. But for polio antigen, what we have done, we have increased our target age. So any children coming to health facility will receive a dose of polio OPV, irrespective of the prior doses that he or she might receive. And the other work is that we try to reschedule our outreach activities and increase the mobile health teams for those eligible children in the inaccessible areas to reach those children. We use the multiple partners, we use multiple stakeholders in the country who can gain access in those areas where we does not have access to reach those children for immunization services. Well, if we talk about the implication of these emergencies on the program, I think in the past 5 years, I would say the worst year for the program in Afghanistan, for EPI-PI program in Afghanistan, was 2020. Unfortunately, we was hit with a pandemic, with the outbreak going on of OPV type 1. There was CVDP cases, and at the same time, there was a kind of quarantine in the country for a few months. The entire activity, the immunity gap really increased in this year, but somehow we could manage to, as I mentioned, we could manage to revitalize and start those activities in the year. Well, as I mentioned, the ban on the polio program was started back in 2018. So you can imagine from May 2018 up to now, there are a few children in the South, not few, I would say 1 million children in the South region where we could not reach them. And the situation gets worse in 2019 and the beginning of 2020, and even up to now. Sometimes even the outreach used to be banned by the negotiations, the local, national, international. We used to have any sort of negotiations to, but fortunately, as per one of our calculation, up to 10% of health facility across the country was banned continuously throughout the year 2020 for outreach services. And then we talk about the performance of fixed outreach. Fixed session was unfortunately banned during COVID-19 pandemic, and that was basically during the quarantine. And the another thing is, as I mentioned, CVDP cases. We have unfortunately 255 cases in Afghanistan in 96 districts of the country, which is within the 24 provinces of the country in 2020. So that is something where our children have zero immunity against this virus. So that was the reasons that we try to have a TOPV campaign. We have conducted, but unfortunately, due to ban, we could not reach to few millions of children. So, as I mentioned earlier, 45% of population somehow missed, and unfortunately, in multiple campaigns in 2020 and even in 2021, where we had our last NID, we were not able to reach up to 3 million of population out of 9.8 million. So the next slide again, it's talking about ban happen in the country, and that ban lead to the immunity gap in the children, and the number of AFB 0 cases has been drastically increased. We can see that the number of AFB cases in 2019 was 33 cases, but unfortunately in 2020 it raised up to 177. So that was the reasons that we try to again have the increase on the age, do multi-antigen campaign in the areas in the south, particularly in Orozgan, Kandahar, and Helmand, Zabul, these provinces. But at the same time, that was unfortunately the challenge. The another problem with this emergency, COVID-19 emergency we face in the program, the borders has been banned or block closed by both sides of. You all know that Afghanistan does not have a lab for testing the polio samples. So for few weeks, our sample was stored in national level, and result of those number of cases that we were selected. But somehow it was managed, but that is an implication of emergency for the program. And somehow there was no sort of activities of immunization, including PI, EPI program, for a few months during 2022 to 3 months, and that lead to 29% decrease in Penta 3 coverage compared to starting from October to 2019 up to December 2020. So you can see if we see it with the wave of COVID-19, we can see like the first wave was like where in the country we had like in the Jan, and the graph was reduced from starting from December up to February, and then in February it goes up because we try to introduce, I'm going to talk about that what we did for restoring our immunization services. Again, for the second wave of COVID-19 in the country, we had in April and May, so that again happened in the country, and the number of cases and then percentage of coverage has fall down.
Dr. Nazari, sorry for interruption. Can you wrap up in 1 or 2 minutes maximum, please?
Well, I'll try to do it in 1 to 2 minutes. So basically, the best practice is to keep our immunization activities vitalized. We have done. The moment the pandemic started, we tried to develop an SOP and send it across the country to help them how to keep the immunization activities goes on, and then at the same time prevent them from the COVID-19 infection. At the same time, we use the media campaign. We try to send our all health facilities and equip them with the PPE kits, except at least a face mask and gloves and sanitizers. At the same time, the moment we received the WHO guideline for prevention and keeping the immunization services active, we translated in local language and we share it widely across the country. At the same time, the other thing is that during the COVID-19 pandemic, approximately for 200 health facility was closed for different time zones because of the health worker was infected, unfortunately, with COVID-19, and they were on leave. So we have calculated and we have seen our data that those 200 case health facility was sort of closed for few weeks in the year. The other thing that we try to do it, the moment the pandemic, the moment the number of cases gone down in Afghanistan in terms of COVID-19 cases, we started multi-antigen campaign in few provinces of the country, including South, which is very important for us for the polio program. We have done the multi-antigen campaign. At the same time, we try to make sure that all vaccinators are there in the health facilities. And if we talk about the program successes, so I think if we had this discussion, we are trying to have the commitment from the government, the ownership and the stewardship from the government. We are trying to, we have like the very close eyes on the VHRDs and those areas. We have really low coverage immunizations, and at the same time, we are trying to have a grip on the overall program for having the increased routine immunization coverage, and at the same time to get access to have the quality campaign for polio eradication, so we can stop at least the emergency of polio eradication, and then we can focus more on the EPI program. So, I in between my talks, I think I talk about all these things: the ban, AGs, the low routine immunization coverage, the unfortunately low cost bidding of BPHS implementers who are implementing the health services in the country. So these are basically the challenges, the challenges that we have in the country, and at the same time, the way forward. Well, we are trying to have our vaccine, COVID-19 vaccines introduction very soon in the country, hopefully by March, as per our plan. With COVAX and Gavi, and at the same time, we will try to build the capacity of the provincial and the national level for any emergency cases or emergency outbreaks happen. So I think I will stop here because of the limitation of time. So thank you so much, everyone, for bearing my voice and bearing with me with the presentation. I'll be happy if there is any question. Thank you.
Thank you very much, Dr. Nazari, for this very comprehensive and very clear presentation, and you shed a light also, and we learn a lot about the Afghanistan and the experience. Multiple emergencies of different magnitudes, and you are coping with all these very difficult situations. So thank you for the presentation. And I have maybe one short burning question that I'll ask you before going to the third one. That as we know that Afghanistan is in the preparatory phase for the introduction of the COVID-19, what do you think? What will be the implication of the introduction of the vaccine or routine immunization and SIAs, either positive or negative?
Well, thank you so much. I think we were thinking that if we go with the introduction of COVID-19 vaccines and using the existing health workforce, I mean the existing vaccinators, there would be a significantly negative impact on the program. So that was the reasons that within our national vaccine deployment plan, we have decided that we are going to hire additional teams to be settled down in the same health facilities and be responsible only for COVID-19 vaccines. So our health workforce could take care of the routine immunization services, and at the same time, we could make the routine immunization activities vital, and at the same time, focus on the polio program. So an entire team will be hired for the implementation of COVID-19 vaccines across the nation, and we will be having few technical assistants and few colleagues temporarily within the national EPI program to take care of the COVID-19 vaccine overall.
Thank you very much. And now we'll go to our third presentation. Our third speaker today is Dr. Steven Soslar. Dr. Soslar is an epidemiologist and immunization senior technical advisor for Gavi. Prior to that, he worked with different emergency, with the different organizations at different also capacities. He provides guidance in his current job and expertise and leadership on a range of immunization programs and vaccine issues. With the emergence of the SARS-CoV-2, he is also engaged in efforts associated with the COVAX vaccine pillar. Before joining Gavi in 2012, Dr. Soslar held key positions at the US CDC, seconded to WHO as the Deputy Project Manager for India National Polio Surveillance Project. Prior to India, he was seconded as an CDC epidemiologist to WHO Central Africa Intercountry Support Team in Gabon, where he served as the Accelerated Disease Control Officer. Dr. Sussler has a PhD and Master of Public Health in International Health Epidemiology from Tulane University School of Public Health and Tropical Medicine. Welcome, Dr. Stephen, for this webinar, and the floor is yours. Please go ahead.
Thank you, Dr. Masheed. I just want to make sure that you can see my screen.
Yes, thank you.
Great, and sorry that I threw it up there a little bit early, Dr. Nazadi. I didn't want to cut you off from responding to your question. Yeah, so thank you very much, Dr. Masheed, for inviting Gavi to speak today. What I would like to try to do is make my presentation complementary to Frank's and Dr. Nazadi's excellent presentations. So in my presentation, I'll try to aim to provide you with an overview of Gavi's new strategic plan and its focus on zero-dose and under-immunized children and communities. And within this, try to draw out and emphasize where there's ongoing work related to fragile and emergency settings and the modified approaches that Gavi is starting to work through so that we can better address the particular challenges that exist in these types of localities. I'm trying to
move the slides.
Yeah, let's see. No. Oh, here we go. Okay.
Okay.
As the founding chair of the Vaccine Fund Board, which was Gavi's initial financing arm more than 20 years ago, Nelson Mandela's vision, determination, and leadership were critical in the Alliance's early days. Now, I can't vouch for this quote that's there. Let's just assume that it's true. Mr. Mandela said that life or death for a young child too often depends on whether he or she is born in a country where vaccines are available or not. Unfortunately, this remains true in many places. In these places, access to vaccines and the availability of vaccines continue to be affected by myriad factors. These could be rural, urban divides, areas of conflict, socioeconomic status, gender. Again, the list is extremely long. But when we consider under 5 mortality in lower income countries, yes, we definitely see overall secular trends. And yet, these trends are even more pronounced in the same countries when we consider mortality due to vaccine preventable diseases. This clearly underlines the power that vaccines offer. And again, the power of immunization is demonstrated both by the high coverage that we're able to achieve with immunization, notably higher than other primary healthcare interventions, as you can see in the left-hand graph, as well as the ability of vaccination programs to reach the poorest segments of society. Again, those elements of society who are the most marginalized and deprived. But behind these global macro figures, where we can get lost at times, there are alarming trends when we disaggregate coverage figures and consider disparities with more fragile countries. When we look at DTP3 coverage, we see that it is significantly lower, 62% versus 81%. And we see other disparities as well, with more than 50% of zero-dose children living in these areas. Gavi's 5.0 strategy, which is beginning this month technically and officially, is for the period of 2021 to 2025. And it has the express mantra, if you will, of leaving no one behind with immunization. What the strategy will attempt to do is really lay down a marker by making explicit and intentional its investments to reach under-immunized and zero-dose children in zero-dose communities in an attempt to ensure that they receive a full complement of scheduled EPI vaccines. Furthermore, and this is what's really important for this discussion, what the strategy and what we'll try to do throughout the Alliance is really use EPI as a platform to deliver other important primary healthcare services, whether that be maternal and neonatal child health services, ANC, nutrition, family planning, HIV treatment. But really, the idea is to leverage EPI as that type of service that can reach, that has the reach, has the sustainability to be able to use as a platform to deliver other services. This is a fairly significant, I would say, departure from our previous strategy, our previous 5-year strategy. The shifts between that previous strategy, which we often call 4.0, and our current strategy represent really the lessons that have been learned and, importantly, the feedback that we've received from national programs, sector-wide stakeholders, and alliance partners, of course, which is all really, I guess, a nice way of trying to say that, you know, we recognize that we need to improve in a number of areas, that mistakes have been made in the past, and that we need to be able to do better in certain areas with certain strategies, and in particular in these fragile areas and localities. By starting with using zero-dose children and communities as a proxy for the most marginalized communities and where the greatest needs are. Again, this is the marker that's laid down. I'll go quite quickly through this, but this is, again, just to highlight that Gavi's support is very much trying to shift and catalyze the inequities in countries by targeting zero and under-immunized communities. And the recognition, I think, that I'd like to highlight, we'll get into more details in the next couple of slides, is that in order to be able to do this, particularly in the fragile and communities most in need, we recognize that we need different partnerships, we need to be collaborating and communicating with other agencies, and there are a number of different, again, areas of collaboration that needed to be expanded upon. This is a bit of a wordy slide, and I won't go through it in too much detail, but this is in a way to lay out that there, how should I say, that there's an understanding in a sense that in order to be able to sustainably reach the most marginalized communities, families and children, that our current mindsets and approaches and partnerships need to change. So a framework to identify and understand the demand side barriers of marginalized communities, refugees, and IDPs that leverages the knowledge, experience, and expertise of these organizations, including, importantly, local community service organizations, so CSOs, in order to be able to really develop those types of approaches that are meaningful to communities. And Frank talked a lot about both the opportunities that this entails, but also the challenges in certain contexts in order to be able to identify appropriate CSOs and partner organizations. Also recognizing that we need to expand the reach of services by doing so through integrated approaches. Both Frank and Dr. Nazadi talked about the power, the opportunity, but also the challenges of integration. Again, integration not being necessarily a panacea, but also recognizing that when you have the opportunity to access some of these communities, you cannot go there with simply one intervention. That other interventions, other important primary healthcare interventions should at least be attempted to be delivered as well. Gavi also recognizes that we need to continue to use data to drive actions and decisions in order to make timely and small iterations and really be able to instill a cycle of improvement and sharing of best practices, particularly in these types of communities. And lastly, advocacy and the importance of advocacy at different levels to be able to push for the inclusion of missed and marginalized communities in our policies, but also the policies of governments, and continually underlying the importance of immunization in primary healthcare in all contexts, with special emphasis, of course, for this discussion and what that means for the humanitarian context. Recognizing, as I said earlier, that this is a departure from Gavi's normal way of working, or I would say probably our comfort zone. We recognize that our current setup is not ideal. So in order to allow Gavi the changes that it requires and the way that it works, the Alliance is revisiting its policies and implementation processes to help facilitate the needed flexibilities so that support can be better differentiated and better tailored to respond to the needs of fragile and complex settings. In areas where government intentionally is not providing services, we need a mechanism, for example, to allow us to support service delivery in these areas. This is often negotiated painstakingly. This often requires high-level advocacy. But again, these are the types of issues that need to be confronted and that Gavi has no experience in doing. So it needs to tap into the landscape of other partners with that type of expertise. So it might sound quite basic and rudimentary, but we went through an exercise to map those agencies that, as I said, really have extensive experience in working in such environments in order to better understand who potential partners could be. We also started to look at our internal processes, our funding mechanisms, and look at those kind of country available resources such as our health system strengthening grants and what might be some of the issues in trying to allocate Gavi's available HSS resources to other partners that aren't typically supported by those. We've seen that at times, for example, that can raise issues and even tensions with the Ministry of Health and our alliance partners if we try to expand our partner network too much. We also understand that expanding that landscape in collaboration with other partners is absolutely necessary to be able to work in non-government controlled areas, because our partner typically is the Ministry of Health, the government, the official government. So sometimes Afghanistan is one of those situations and contexts, for example, and Dr. Nezhati spoke about this, where expanding partners and I would say modalities of support are really important. This is an extremely busy slide that I won't go through, but I believe that everyone will have this slide set so they can look at it in detail. But it's to illustrate what's been happening over the last year or so as we've started to prep to move into our next strategic plan. Again, with the full recognition, as I mentioned before, that different ways of working needed to be found in different partners to be able to be effective in these particular areas. So again, we have some of the usual suspects that are here, but we're also in the process of speaking with other organizations and also, importantly, understanding what is the landscape of potential partners within countries, not just at the global level, but in countries that could potentially make a difference and really be able to partner with our in-country colleagues. This is my last slide, and it simply speaks to some of the more operational aspects of where we find ourselves and the steps that we want to take to continue to expand our effectiveness, our scope, I would say, and our effectiveness in working in this area, because it is admittedly fairly new. So as I mentioned, we're going to continue to sign additional partnership MOUs that highlight areas of collaboration and comparative advantage where organizations might have those. We see this as key in order to be able to continue to create strong and visible commitment from the Alliance, so not just Gavi, but our Alliance partners, WHO, UNICEF, Gates Foundation, and our expanded partnerships with various CSOs on the importance of engagement with other humanitarian partners in these settings. We need more partners who can effectively implement where our traditional partners cannot. In addition, enabling the operational environment that incentivizes these new partnerships is a priority for our country-facing teams. And as I mentioned earlier, being able to facilitate the engagement of new partners at the country level through the complex nature of Gavi's processes, reviews, audits. In this one bullet point, I apologize, you have a number of acronyms that probably make the sentence, the bullet point, barely intelligible for the non-initiated to Gavi. As well as supporting engagement with new partners in regional working groups. So we continue to use regional working groups as a focus area where we can discuss these issues, get feedback from partners, and really try to be able to look kind of transversely across the different partnerships that we try to maintain. And again, in this newer area of work related to humanitarian and emergency contexts, we really do need all the help that we can get. And then I guess just lastly to say that, and I think both Frank and Dr. Nazari touched on this, my presentation was trying to speak specifically to Gavi's support for humanitarian emergency localities, and the imperative of the present pandemic, the needs that have obviously been increased because of this, with the pauses in immunization, with the pauses in the delivery of other primary healthcare systems, only further emphasizes the need to really look at this area and to try to move forward as quickly as possible, both programmatically and operationally, but then tying in to those activities, the need to continue to have advocacy at all levels. Again, advocacy at the global, regional, and country level to try to continue to push and advocate for those missed populations. Dr. Majed, that was
Thank you very much, Stephen, for this highly interesting and equity-focused presentation. And thank you also for this complementarity between the three presentations. So we have different pieces of the puzzle. So I think this equity and the emergencies, and you have a case from a country, it was very informative. And thank you again for this presentation. Now we will have our session for the Q&As. First of all, I'd like to thank Frank for his active responding to many questions during the presentation. So maybe this is the advantage of being the first one. Thank you, Frank, for answering many questions. And there is some questions have been selected that you would like to respond. So there is one question regarding the aid effectiveness in supporting immunization during the COVID-19 crisis. And I think this is very important issue. So please, Frank.
Could you repeat the question again? Yeah.
About how did you assess the role of the global aid effectiveness in supporting immunization during the COVID-19 crisis?
Okay. Well, I think the global community has responded to the global crisis. We all recognized that there was a negative impact of COVID on immunization services. Gavi provided some flexibility in the funding to address those issues. Many of the partners are addressing that issues to support. I think the impact has been quite variable. Most countries, my sense is most countries experience an acute drop in coverage for, the beginning of the pandemic for March and April of last year, and that they've gradually been recovering. I haven't seen a lot of sustained negative data, but maybe Stephen or others could have some comment on that.
Yes,
I think most of the impact on coverage, it's a mixed bag of both vaccine hesitancy. People don't want to worried about getting COVID going to the health facility, as well as the outreach teams that were stopped from going to the field because of the lockdown measures. But I think those issues are gradually being addressed. Steve, did you want to add anything?
Yeah, sure, Frank. I mean, I've seen some data and statistics from different regions, and first off, it does seem to be fairly country specific, but there do also seem to be some pretty broad trends. One of the trends which is interesting is that when you do compare immunization, I guess it speaks a little bit to what I had mentioned in my presentation. When you see the downturns in immunization and compare those against some of the other primary healthcare services that are often delivered at the same time or from the same clinics, immunization hasn't done as poorly as some other primary healthcare interventions, which is somewhat encouraging, I guess, if you're only wearing an immunization hat. But if you're thinking about primary healthcare and broader issues, then it also continues to speak to the need to look at integrated delivery of services, to think how we can strengthen these platforms, not just immunization in and of itself, but the systems to be able to deliver a fuller complement of health services.
Okay, thank you very much for the answering this question, and I'll go now to Dr. Nazari. Dr. Nazari, one question, I think with the increasing the number of CVD-BVs outbreaks globally and even in Afghanistan, the number is much higher. So, and unfortunately in many countries, some of the lessons learned that due to the engagement of the health or the surveillance staff, particularly the AFB staff for the response of COVID, that have been affected also and leads to more spread. Can you elaborate more about the experience in Afghanistan and also using some of the lessons learned for future plans and strategies?
Well, thank you so much. If sorry, doctor, your voice was cutting. I will repeat, or maybe you can repeat. You were asking about the number of CVDP and the use of surveillance people for the COVID-19, finding cases of COVID-19, right?
Yes.
Okay, so as you know, unfortunately, the CVDP cases, the first CVDP case was found in eastern side of Afghanistan, and that was linked genetically with the cases in KPK, Pakistan. But as I mentioned in my presentation as well, that the entire target population for was totally zero immunity was there, because we ruled out basically in 2016 type 2 OPV from our program. So that was the reasons that it very much widely went to across part of the country. And we experienced a number of environmental sample positive for type 2 vaccines across the country. And then but fortunately, in all other sides of the country, by having a TOPV campaign and good coverage of routine immunization and IPV, we could manage to stop it, that there was no circulation. But unfortunately, in southern side of the country, as I mentioned, there is low coverage, so it is still there, and it lead to 255 cases. While on use of the surveillance, the VPD surveillance, AFP surveillance for the COVID-19 vaccine case finding, it was something that since we had a huge network for polio eradication for the surveillance, we try to use them in the beginning of the pandemic in the country. And I think that was something where we feel that it is always good to do the integrated works, but somehow at the same time, while we are thinking about the eradication, we need to keep focusing on the main indicators, which is the eyes, I would say the eyes and ears of the program, which is the surveillance. So it's somehow I personally feel that during those initial 3-4 months that where the entire polio surveillance network was busy with the COVID-19, somehow their focus was deviated from their original work. And although we could very soon we could revitalize, and then we developed those SOPs and send it to them, that at the same time while they are working for COVID-19 vaccines, they have to keep focus on the polio as well. But it was an experience that without having a proper SOPs and proper documentation for the field people to look at the two different activity is something that we should not practice in future. That was the biggest lesson learned we found out and after involving of the polio surveillance team and COVID-19 vaccine. Thank you.
Okay, thank you very much for your answer. And I have here a question. I think this is to Stephen. And as I understand now, there is a focus by Gavi on the 0 dose and also about new strategies and how to identify the 0 dose children living in fragile emergencies, and about these tools and strategies can be carried out by local health staff. And I think Gavi is recently developing something on that. Could you elaborate more on this, Stephen, please?
Sure. I can elaborate somewhat generally, but at the same time, if the request is to share further information, I can put people in touch with other people. But yes, the idea is that more explicit tools are shared that can be used down at the local level to be able to identify these types of individuals and communities. The issue, I think, that what we're coming up against right now, whereas this was meant to be the utmost focus of the Gavi strategy as we initiated 2021, is that much of our staff and much of our partner staff is very much involved in other activities related to COVID, whether it's COVID response directly to the pandemic or preparing for the eventual rollout of COVID vaccines. And so we are going through some internal discussions with our partners as well to be able to think about how to reprogram some of these activities. But the specific question related to specific tools that can be used at the country level, I can certainly put other people who are working on that more than I am. I can put them in touch with the person who answered the question. If they send me, again, a message in the chat, I'm happy to put them in touch with the appropriate people.
Okay, thank you very much for this clarification. And also another question to Dr. Nazari about the Afghanistan and this chronic emergencies and assistance, and also for the outbreaks, the current outbreaks for the polio and the elevated numbers. So this year, maybe 2020 was the highest over the last few years, and the relationship between different emergencies, and also if there is any new adaptation for long-term or change in the strategies for such emergencies.
Well, thank you so much. Well, I think that the most important thing is that what we have experienced in the country while the pandemic started, we had like 2-3 emergency centers within the Ministry of Public Health. We find out that there was one emergency for basically we call it the CCC, where they are basically the for any kind of, as we are in a state of war in Afghanistan. So that center was basically responsible for the emergency cases when some bomb blast or something happened in the country. So there was a huge network working under that department. Then we had the emergency for polio eradication. And at the same time, like there was an emergency within our partners in between WHO and UNICEF. So what we have experienced that if we can jointly make one comprehensive emergency center for all such emergencies, then at the same time we make our staff capable, or the capacity building need to be done in a way that in case such emergencies come into the picture, they can focus on their work, and at the same time they can collaborate and on the new emergency to respond to those emergencies. That was something that unfortunately was not there in Afghanistan, and we learned and following that after the first wave of COVID-19 in the country, what we have done within the government of Afghanistan, the entire emergency centers has been come down under one umbrella. So all the emergency centers in Afghanistan is now there in the EUC building, where we call it the EUC. So the Emergency Operations Center, of course, for polio eradication, but all other people are working under the same umbrella, and there is one particular focal person to manage all these departments together. So that is something that we have experienced in the country, and we try to fix it after the first wave, and we somehow responded to the second wave of COVID-19. And at the same time, revitalize our activities for polio and revitalize our activities for routine immunization in the second wave, very pretty and very much better compared to the first wave of COVID-19 vaccine when we had the emergency in the country. Over.
Thank you very much. Another question, maybe it could be a general one. I'd like to ask Frank and then other colleagues also to elaborate. And I see several questions about the misinformation about the infodemic and the effect on, especially in emergency settings, and how it affects also the utilization of vaccines, and what are the current strategies and the current work by different international organizations to work on this area. Frank, please.
I think this is a big problem, Dr. Majid. I think we all recognize there's a lot of mistrust, and so I think it's a negative impact. I mean, a country like the Philippines had a huge measles outbreak because of vaccine hesitancy. It related to introduction of a dengue vaccine, and people stopped bringing their children for immunization, and shortly thereafter, in 1 or 2 years, they were having massive measles outbreaks. And so I think it's an issue all throughout the world, and I think there's a lot of work that needs to be done to combat the misinformation about vaccines. I think this RCCE, this community listening approach is taking off. There's a collective being done between UNICEF and WHO and other partners to use this community listening approach to rapidly identify this misinformation and quickly respond to it. I know when we worked in Nigeria, when we had problems with misinformation about the polio, we developed essentially a rapid response team, like you would for an outbreak, but it was responding to rumors and misinformation. And the government had to develop capacity for a rapid response to address these issues of misinformation. And very often, as I remember, we used the same tools that whoever was spreading misinformation, if it was Bluetooth or whatever, we would combat it with the same mechanisms that it was being used to disseminate the misinformation. And of course, it was important to engage community leaders, trusted people, to address the misinformation, people that the communities would respect their opinions. And so I think it's important, particularly at the local level, to understand who the community will listen to for advice on medical care and bring them on board to help deliver messages, and very often that's the formal health sector, doctors and trusted medical providers that a community will listen to.
Stephen, would you like to add something?
No, I don't have anything further to add. Just to really underline that last point that Frank said, at the community level, it's often the local health personnel that are the most effective people at providing the messages that we want. So making sure that they're up to date on everything, that they don't have any of their own concerns sometimes is also necessary.
Okay, thank you very much for this highly interesting presentations, answering the questions. Thank you for the audience for their questions, which enrich also the discussion. And I'd like maybe to have 1 or 2 minutes to speak about key takeaways or key messages from this webinar. As you understand that there is a large number of zero-dose and under-vaccinated children residing in fragile and conflict settings. There are also successful models of reaching the communities that include resilient systems, engagement of trusted partners, and innovative service delivery strategies that we need to learn and also to share experiences between different countries. From our region, Dr. Nazari also mentioned some best practices in Afghanistan, for example, using community-based surveillance network for demand generation, and how can we make a better utilization of some learned lessons also from the presentation of Dr. Stephen and Dr. Frank from different countries, different experiences, how can we generalize it? At the global level, I think the advocacy, either globally, regionally, or at country level is a key component, and it should focus on missed population, including in the context of the COVID-19 pandemic and also for vaccination. So I think there is too many lessons learned, and we need to apply and to share experiences between different partners. Thank you very much for being with us. Thank you for audience for your presence, and we wish that we will have maybe future webinars and furthermore discussions on other related areas, and equity emergencies are key challenges in our region as well as globally. Thank you, wishing you all the best, and good evening. Bye. Thank you very much. All the best.
Thank you so much, everyone. Thank you. Have a nice day and nice good night for everyone.